morning, everybody. Welcome. We are very happy to join you. We have a great panel here for you guys this morning. Thank you very much to Leipzig. Thank you very much to Concept Medical for supporting this symposium. This symposium will be discussing a lot with Sirolimus Coated, the MagicTouch Sirolimus Coated Balloon into the fistula space. We have a panel from esteemed colleagues from the UK across to Singapore. I'm Dr. Katsanos from Greece, and we've got Dr. Jaffer, Dr. Chang, Dr. Tang joining us. We have prepared for you a couple of cases, a lot of evidence, a lot of discussion on the basic biology and pharmacology from Aloke, and hopefully a very juicy discussion for you at the very end. So we hope that you enjoy this morning's session, and we are off to the first talk.
Good afternoon. I'm Aloke from CV Path Institute in Gaithersburg, Maryland. I'm going to talk to you about treatment of AV fistula with DCBs, advantage of sirolimus over Paclitaxel. These are my disclosures. So, brief introduction. Following observations from a traumatic arteriovenous fistulas caused by mechanical injuries, Dr. Bresca, Semino, and Hurwitz first described the creation of radial cephalic AV fistulas in the forearm, forming a side-to-side anastomosis between the cephalic vein and the radial artery in 1966. This is the original New England Journal of Medicine paper I'm showing you here. And this really revolutionized the care for hemodialysis patients. And despite the introduction of new fistula surgical techniques and locations over the last 54 years, AV fistulas are still mired by high primary failure rates. The pathophysiology of stenosis in AV fistulas and AV grafts is very different from that after angioplasty. It is believed that ongoing neointimal hyperplasia or proliferation in AV fistulas and AV grafts is due to non-physiologic flow dynamics that develop when there is direct anastomosis of a high-pressure arterial system with a low-pressure venous system. And mechanical factors also contribute to ongoing needle hyperplasia, including needle punctures, et cetera, that lead to endothelial disruption and fibrotic wall changes. I'm showing you down below a little illustration of the kind of shear forces that occur in a fistula. You can see at the site of the anastomosis between the artery and the vein, there is some high flow, but after you get into the distal areas of the vein, you get a lot of low shear areas, which probably builds up stenosis, causing a fairly high rate of AV fistula failure. What are the costs of maintaining vascular access? The cost of treating patients who has a failure of HD access graft is amazingly high. It's estimated to be in the range of $62,000 per year. Then the cost of treating a patient who does not have AV fistula failure. Therefore, preventing AV graft failure or fistula failure is extremely important and could have favorable cost-benefit ratio for the medical system. Multiple percutaneous techniques and tools have been used to treat neointimal stenosis that develop at the site of venous anastomosis of AV grafts. At best, the secondary patency of AV grafts is about 50% at 3 years after the creation of vascular access. Typically, multiple interventions, as you all who are familiar with this area know, multiple interventions are required in these patients to keep these fistulas open, and a lot of times it only lasts so long. Well, what are the drug-coated balloons that are approved for AV stenosis? In the United States, at least, there are two FDA-approved DCBs. One is the Impact Admiral from Medtronic. That's a dose of 3.5 micrograms per millimeter squared. The other is Lutonix DCB at a dose of 2 micrograms per millimeter squared. They both also have CE mark. These are the data from the randomized trials, the pivotal trials that allowed approval for these devices. You can see here on the left, the recently published Medtronic trial, which showed basically a significant benefit in terms of graft patency at 210 days after with the Medtronic impact balloon versus the PTA. On the right was the Lutonix trial, which showed perhaps less success, didn't meet the primary endpoint at 6 months, but still a difference between the two products. Why do we need a sirolimus DCB? Sirolimus is a standard for coronary artery disease treatment via DES and proven to be safe and effective. There's certainly no question about sirolimus' safety and impact on mortality. Paclitaxel modifications, the crystalline form needed for DCB delivery, mean coating integrity and transfer are variable with substantial portions lost downstream into the body and the tissues. And loss of paclitaxel into the body remains a significant safety concern, which is perhaps highlighted by the meta-analysis of Katsanos published in 2018. And one of the real issues with this was understanding where the paclitaxel went and that there was still remnants of paclitaxel lost into the body, and whether that could perhaps be an explanation for the increased mortality. Well, what is known is that there certainly is evidence of downstream embolized paclitaxel in preclinical models, as we've shown in the porcine SFA model, where you do a DCB in the femoral artery and you see downstream emboli there, either embolized paclitaxel or signs of paclitaxel effect. It's also known after coronary angioplasty, when you use Paclitaxel coated balloons, you can get a slow flow phenomena as well as getting impaired coronary flow reserve after these balloons, which are also significant concerns. Paclitaxel safety concerns, I'd also say, persist. You know, SweetPad was just published recently in New England Journal, which is, of course, a randomized trial where they did an interim analysis and did not show any effect of paclitaxel-coated devices on all-cause mortality out to about 2.5 years. And although the FDA wrote an editorial for this paper, they say the data were comforting but limited, not long-term follow-up. As you all know, a fair amount of paclitaxel is lost into the body, as shown by the paper of Kelch and many others, and the transfer is not very efficient. This slide shows the total amount of dose delivered to the body from an impact balloon. You can see in the milligram range for most sizes of impact balloon are delivered to the body. If some of that is lost into the body, that will be the dose delivered to the patient. So sirolimus offers potential benefits over paclitaxel. And that's well known. Sirolimus, of course, is equally effective, if not more effective, in inhibiting muscle cell proliferation and migration. It has a better safety therapeutic range, a wide therapeutic range with a better safety margin than paclitaxel. This is well known. And although its problems are tissue absorption is slow and retention is short, whereas paclitaxel is certainly has the advantage here in terms of tissue absorption and retention. So technical challenges. What are the reasons why we don't have a paclitaxel-coated balloon currently? Well, certainly we need to enhance tissue absorption. It's difficult to get sirolimus to enter the arterial tissue within the 30 to 180 seconds needed, and we need some sort of instant glue. And then once we get it there, we need to retain its delivery over time so that it has a therapeutic effect on the restenotic cascade. This is the data from the MagicTouch balloon in terms of arterial wall PK levels in the coronary model. You can see the nice effect of the MagicTouch balloon on sustained arterial wall PK levels out to at least 60 days. I've shown you the data here. This is why this solution is effective in causing an anti-restenotic benefit. And this MagicTouch solution, just to remind you, is really sub-micron phospholipid particles which contain sirolimus, which release them in a time-release mechanism, allowing this to work properly. This is the data from Raman spectroscopy showing you essentially, we've here done a study of encapsulated versus free sirolimus in the porcine coronary artery model. We're looking by Raman spectroscopy at the free versus the encapsulated sirolimus. Free is shown in the pink bar and encapsulated is shown in the green. You can see free sirolimus tends to partition throughout the artery wall, as shown in 7 days. There's less of it at 28 days. And there is a transition between the encapsulated form and the free form, which is what the technology is meant to do. This is the histology in an ISR model, an in-stent restenosis model in the porcine coronary artery, showing you essentially that MagicTouch had very good healing, no evidence of toxicity versus the plain old balloon angioplasty for treatment of ISR. And when we looked at the histologic reaction, what we found was significantly increased fibrin with a MagicTouch 1x dose of balloon versus a POVA, suggesting a good effect in terms of biological availability of sirolimus. We would not expect to see an effect on stenosis in this model. AV fistula model we are currently conducting. This is done in the porcine model, where we connect the iliac artery and the femoral iliac vein, and the femoral artery together make a fistula, and then treat this fistula over time and look at the effect out to 60 days. Here's how we indicate biologic efficacy. We can look at things like endothelial cell loss, fibrin deposition, proteoglycan, collagen content. All of these would be indicators of drug effect. And we can also sample the downstream skeletal muscle beds for evidence of embolized sirolimus, et cetera, to look for any effect on downstream muscles. Here's an example of a paclitaxel living balloon in the AV fistula model. Here you can see at the anastomosis where the artery and the vein have been anastomosed, and after the DCB balloon, the paclitaxel living balloon, as well as the POVA. And you can see the distal vein has a lot more neonatal hyperplasia as expected, consistent with the pathophysiology of AV graft or AV fistular stenosis. And you can see some evidence of drug effect with some residual fibrin proteoglycan replacement in the downstream vein versus a POVA. And although I don't have the data fully analyzed yet, this is an example of what MagicTouch showed in the AV fistula model. This is an ongoing study. You can see the artery looks fairly normal. This is the downstream vein I'm showing you with intimal hyperplasia, no evidence of untoward toxicity, and I will be presenting this very shortly. The study is currently under analysis. So in conclusion, sirolimus is certainly the preferred drug for intravascular interventions. Paclitaxel coated balloons are limited by a high rate of distal embolization and loss of paclitaxel into the body. These concerns were only heightened by the analysis of Kitsanos and may be a concern with the treatment of AV fistula where embolization to the venous system and lungs are a potential concern. The MagicTouch Sirolimus Coated Balloon demonstrated successful drug transfer to the arterial wall out to 60 days. I showed you that in the PK model. The ISR study at 30 days showed no evidence of toxicity. I think I showed you fairly good healing and some evidence of drug effect, showing a promising effect on restenosis. I think overall, this represents a very important and promising new technology for the treatment of AV fistula and AV graft stenosis. So with that, I'd like to end the talk and thank you for your attention.
Thank you for the chance to share with you some of our experience in the use of Sirolimus Coated Balloon in the dialysis circuit. A functioning access is critical to the delivery of life-saving hemodialysis therapy in patients with end-stage kidney disease. However, neointimal hyperplasia often occur within the dialysis circuit, resulting in stenosis, poor flow, and ultimately thrombosis of the circuit. The situation is worse in patients who have poor veins and require AVG creation. Neointimal hyperplasia often occur at the graft-vein junction, which can ultimately lead to thrombosis of the circuit. Although we are able to successfully salvage thrombosed AVG either through open or endovascular intervention, the patency rate after successful salvage remains poor. Based on the literature, the average 3 and 6 month patency rates post-salvage are 49% and 38% respectively. This implies that up to 50% of the patients who had undergone successful salvage will be back again within 3 months. Sirolimus Coated Balloon has been used successfully in coronary artery intervention by preventing intimal hyperplasia in the arterial system. Since the primary pathology in AVG thrombosis is neointimal hyperplasia, we therefore postulate that the application of Sirolimus Coated Balloon at the graft-vein junction after successful endovascular salvage will minimize neointimal hyperplasia and result in improvement on the patency of the AVG. Hence, we carry out a single-center prospective study of 20 patients who presented with thrombosed AVG. Sirolimus Coated Balloon is applied at the graft-vein junction after successful endovascular salvage, and the patients will follow up at 3, 6, and 12 months with duplex ultrasonography. The primary endpoint was set as primary patency rate of the AVG at 3 months, and the secondary endpoints were the patency rate at 6 and 12 months. A total of 37 patients were screened and 20 patients were recruited over a 1-year period. The last patient was recruited in September 2019. Patients were excluded from the study either because they had coexisting central vein stenosis, failed thrombolysis, had residual stenosis, or required stenting of the graft-vein junction. The result of the study up to 6 months was recently published in JVIR. I shall share with you the results that was published and of course the recent 12-month outcome today. These are the baseline demographic data of the 20 patients that were recruited. The median age was 68 with a predominant female population. The etiology of ESRD was diabetes mellitus and hypertension in majority of the patient, and up to 50% of them were on antiplatelet therapy prior to the intervention. The median vintage of the AVG was 14 months and were predominantly in the upper arm. TPA was the predominant thrombolytic agent used. It is used in 2/3 of the cases. 7 mm high pressure balloon was the predominantly balloon used to treat the culprit lesion, and cutting balloon had to be used in about 20% of the patient. The size of the Sirolimus balloon used ranged from 7 to 8 mm. Most significantly, none of the patient has any significant residual stenosis or thrombose after the procedure. This is the result of our study. The primary patency rate at 3 months was 76.4%, with 3 patients experiencing rethrombosis within 90 days, and 1 had repeated angioplasty performed for low flow. Therefore, the primary extended patency at 3 months was 82.4%. 3 patients exited the study due to complication before the 3-month endpoint. The complications were unrelated to the use of Sirolimus Coated Balloon. 1 patient had surgical revision of the A limb for pseudoaneurysm formation 8 days after successful thrombolysis. 1 passed away from intracranial hemorrhage, and 1 had explant of the AVG at day 88. Significantly, these 3 AVG were still patent at the time of event. The primary patency at 6 months was 64.7%, as 2 patients had reintervention of the SS at 134 and 157 days respectively. The primary assisted patency rate was 65% at 6 months. This is how the Kaplan-meier curve looks like. The projected mean primary patency was 285 days. The 95% confidence interval was wide. It ranges between 194 to 376 days. This is how the actual primary patency rate at 12 months looks like. As you can see, there is a progressive decrease in the primary patency rate across 12 months, which is not unexpected. At 12 months, the primary patency rate was 35%. With endovascular intervention, the primary assisted patency rate is actually 47%. The number of AVG that was abandoned at the end of 12 months was 5. Now, if we compare our results with all the other studies in the literature, the average reported rate ranges from 49 to 38% at 3 and 6 months respectively. And therefore, the Society of Interventional Radiology actually suggests a threshold target of 44% at 3 months and 31% at 6 months. In our center, we are able to achieve a rate of about 55.5% at 3 months and 85.8% at 6 months. In patients with recurrent thrombosis, we attempted to treat them with Paclitaxel coated balloon, and we can achieve a 3-month patency rate of 43.6% and a 6-month patency rate of 23.1%. In comparison, in our pilot study of 17 patients, we are able to achieve a 76.4% patency rate at 3 months and a 64.7% patency rate at 6 months. If we include all the 20 patients in the study, the patency rate was still superior to what was the suggested threshold by the Society of Interventional Radiology. Now, if we compare our study with what is reported in the literature in a randomized controlled study, where cutting balloon were compared to plain balloon, you can see that in the cutting balloon study, the average 6-month circuit patency rate with cutting balloon is 37.5%. In the study by Vascular, where he compared use of stent graft versus plain balloon, he's able to achieve a 6-month circuit patency rate of 34.2%. Our study, although it's a small study, we can demonstrate a patency rate of about 35% at 12 months. This is one of the patients that were recruited in our study. This is the appearance on DSA post-thrombolysis. As you can see, there was adequate treatment of the graft-vein junction after the application of the Sirolimus Coated Balloon. The patient remains well and does not require any intervention for 13 months. And this is the appearance on DSA. When she represented with high venous pressure, we showed a recurrence of the graft-vein junction stenosis after 13 months, implying the durability of Sirolimus Coated Balloon in the treatment of graft-vein junction stenosis. Having proved that the Sirolimus Coated Balloon is effective in inhibiting neointimal hyperplasia in the dialysis access circuit, and combined with the results that Dr. Tang is going to share in the subsequent lectures, encouraged by the result of this study and the result of the pilot study that Dr. Tang is going to present next, we took a leap of faith to hypothesize that Sirolimus Coated Balloon will be superior to plain balloon angioplasty in maintaining access circuit patency. And we chose 6 months primary circuit patency as our primary endpoint. We started a prospective, multi-center, double-blinded, randomized controlled trial where we allocate 170 patients with dysfunctional AVF into 2 groups, Sirolimus Coated Balloon versus plain balloon. These are the inclusion criteria. The first 3 criteria are designated as preliminary eligibility criteria. The last criteria is can only be determined during the procedure, which is the successful angioplasty of the underlying stenosis, defined as less than 30% residual stenosis on DSA. This is how the recruitment process looks like. Patient who does not fulfill the preliminary eligibility criteria will not be enrolled. Patients who are enrolled had already fulfilled the preliminary eligibility criteria during the procedure. If the patient has more than 30% residual stenosis, they will be considered as screen failure and will be replaced with a new patient. Patient who has less than 30% residual stenosis will go on to be randomized. They are randomized in a 1:1 ratio, where they'll be randomized to either receive treatment with Sirolimus Coated Balloon, or they'll be randomized to be treated with a placebo plain balloon again over the treated area. Before discharge, the patient will receive post-procedure ultrasound scan to document the result, and they will go on to have post-procedure ultrasound scan at 3, 6, and 12 months after the intervention. Randomization is via a secure web-based randomization program developed by the Singapore Clinical Research Institute. The study is double-blinded. The patient and the study team will not know the treatment allocation. Only the study coordinator remain unblinded throughout the entire study. Each site has an emergency code break envelope where only the site PI can break the blind in the case of emergency. Our first patient was recruited on 11th January 2021. Since then, a total of 6 patients in 2 sites have been recruited as of 22nd January 2021. In conclusion, application of Sirolimus Coated Balloon in dialysis access circuit appears to be safe and effective. Larger randomized controlled trials are ongoing to verify our findings. With that, I thank you for your attention.
A very good morning from Singapore. I would like to thank the organising committee for giving us this opportunity to present our 12-month outcomes from the MATILDA study. These are my declarations for this talk. So in this introduction, Paclitaxel coated balloon angioplasty in AVFs remains controversial. Depending on which study and which meta-analysis you look at, there may be some efficacy in its use, or there may not be any at all. But overall, from this meta-analysis, it shows that there is some efficacy at 6 months compared to plain balloon angioplasty, but the efficacy falls at about 12 months, and then that is a pooled result of about 47.5% primary patency rate at 12 months. So the aim of this study was to evaluate the 6-month and 1-year outcomes of the MagicTouch Sirolimus Coated Balloon-Angioplasty for dysfunctional AVFs. These were the study endpoints of interest, including a safety endpoint, which was freedom from localized or systemic serious adverse events and mortality through 30 days. We also looked at access patency, target lesion primary patency, and technical success. The study site was Singapore General Hospital, where we do over 3,000 access salvages a year in the Vascular. We enrolled from May 2019 to January 2020. The inclusion criteria were a bit liberal, but we included lesions that did not have any clinically significant dissections. All lesions had to be effaced properly with a high-pressure balloon prior to drug elution, and we could include one further additional lesion in the circuit. And the reference vessel diameters were between 5 millimeters to 8 millimeters in maximal diameter. Just looking at the patient demographics, you can see that these were quite high ASA gradings of patients. About 2/3 of these were Chinese in origin. We recruited about 72% were recurrent lesions, and these were all in mature circuits. Turning to procedural details, the main indication for intervention was dropping access flow. We treated 47 lesions in 33 subjects. The majority were non-juxta-anastomotic lesions. Looking at treatment outcomes, we had 100% technical success and 100% freedom from device or procedure-related mortality. The 6-month primary patency, which has been previously presented, showed that the primary circuit patency was about 68% and a target lesion primary patency of about 83%. This is the slide of interest for this talk. You can see the 12 months results. The target lesion primary patency falls to about 58%, and the primary circuit patency drops to about 44%. The mean TLR free time is about 10 months, and the mean time to target lesion reintervention is about 6.8 months. If you look at some of the subgroup analyses, it did not matter which type of lesion. There did not seem to be a difference in between JAS or non-JAS lesions, although there was a tendency for reintervention on JAS lesions. And whether there was de novo or recurrent, were very similar in terms of reinterventions. Looking at the reinterventions themselves, between 6 to 12 months, which seems to be the more time for higher interventions, there were, for the majority, were recurrent lesions. And the mean number of reinterventions prior to this target procedure being enrolled into MATILDA was an average 2.1 times. And 6 out of those 7 circuits were with JAS lesions. This is an example of a use of a MagicTouch balloon with the ulnar basilic AVF. You can see the balloon tracks pretty well around the anastomosis. This is a follow-up of a patient who's had a mid-forearm radiocephalic fistula with 2 lesions between 2 aneurysmal segments and 1 near the elbow. Difficult places to put stents, and between baseline and 12 months, you can see that the follow-up duplex scan shows that there is some regression actually of the restenotic area, neointimal hyperplasia area, and this patient has yet to have a further intervention at 12 months. So in conclusion, ladies and gentlemen, Mr. Chairman, The results on MATILDA show excellent technical and clinical success rate. It is safe with no serious adverse associated events with its use. It is efficacious. The one near target lesion primary patency does drop, but it's comparable, if not superior, to the current Paclitaxel data. However, we need longer-term data, and randomized controlled trials are urgently required to determine SCB efficacy in the AVF circuit. It may be that we do need a top-up of the drug after 6 months when the half-life of this disappears. Thank you very much for listening. And I would like to thank my MATILDA investigators for their help in recruitment.
Good morning, everybody. My name is Chong. I'll be showing you an AVF angioplasty case with the MagicTouch drug-coated balloon. These are the operators that are with me for this case. This is a 77-year-old female, previously RC AVF, now with a BC AVF, successfully cannulated, now presents with difficulty cannulating the AVF. We do a ultrasound scan showing the upper arm, mid-upper arm venous and stenosis. You can see it's hemodynamically significant. This is our operating room. We do this in the hybrid operating room, and this is the patient positioning over here. The duplex ultrasound is initially performed from the brachial artery. You can see the anastomosis there in the middle of the screen, showing widely patent, and going up the upper arm, going towards the shoulder. It looks still pretty decent, and very soon we will see the area of concern. So now we can see that the vein is getting small. You can see why there is difficulty cannulation, and that's why the perm cath was still being used. This is in line with the duplex ultrasound scan and shows that this is indeed a hemodynamically significant stenosis. Cannulation of the fistula can be done in several ways. I prefer to go uphill in this case, given the location, and using the micropuncture kit you can see over here, with the vein in transverse, making sure we get the 12 o'clock position, and then getting blood back. And using the micropuncture kit, I think, minimizes trauma to the vessel. Of course, with an AV graft, this is not necessary, but in this case, I prefer to be safe. This is confirmation that the wire is in the vein, and then switching out for a 6 French bright tip sheath. The sheath we use is a merit sheath. It's 4 centimeters in length. The short length is, we think, very purpose built for the fistula interventions. As you can see over here, the patient is lying supine. We do this with the patient just under local anesthesia in the area of puncture. Patient is fully awake. They usually come in between their dialysis sessions, so they do not have to stay overnight. They do not take up a hospital bed, and more importantly, they don't take up our dialysis chairs. So this is the typical way we perform these procedures. The initial angiogram seen over here, minimizing radiation to all involved, shows that there is a tight stenosis in the mid-upper arm, consistent with the duplex ultrasound, and you can see the brachial artery seen. That means it's a hemodynamically significant stenosis. We do not even have to do a reflex angiogram. It's important to continue with the central venous angiogram, and it shows the basilic and the cephalic system both patent, no cephalic arch lesions, which is a common problem, and the central veins are not giving any issues at this time. So this is good for the patient. Next, we try to traverse the stenosis with a 035 Terumo glide wire. It's hydrophilic in nature, and usually for stenosis would allow us to perform the interventions over the 035 platform, which is preferred. However, you can see it is indeed quite tight, and despite some maneuvering of the artery, we're still not able to pass the stenosis easily. In this case, we can use an 018 wire or use the 4 French Berenstein catheter for support, as shown over here. So Berenstein catheter is also one of the common support catheters that we use. It's got some directionality, which we like for this case. So with some persistence and patience and luck, we're able to slowly get through the stenosis, as you can see from the video over here. So after we get past the stenosis, it's very important to confirm that we're in the true lumen. Dissection is obviously not a great outcome. So once we're in true lumen, we use the old roadmap. We put it over an 035 non-hydrophilic Teflon wire, and this is forms the basis of our intervention. The first step would be an angioplasty with a POBA 8x60mm Boston Mustang balloon. It is a relatively non-compliant balloon, and you can see over here we take our time going up with the pressures, trying to minimize vessel trauma, and taking time to get to nominal atmospheres. You can see that there is many lesions, and this is probably the culprit lesion over there. And slowly, with some patience, it will eventually pop, as it will be shown very shortly. There we go. So now we do an angiogram, and it shows that that lesion is much better. However, there is a lesion further upstream that we need to also involve more ballooning. So this will be continued with the same balloon. We like not to have to open too many balloons, and do the angioplasty above the previous angioplasty site. The roadmap really helps us make sure that we don't have any geographic miss. You can see there is no tight stenosis that we saw earlier. And for good measure, we also balloon closer to the anastomosis. After this, we do the angiogram, showing that it is much better. You can see the brachial artery is no longer being lit up. There is a bit of stenosis, but I think this is spasm because we compared it to the initial angiogram, and it shows that this lesion wasn't there before. In general, we do not go about chasing these kinds. These are the 3 operators for this. Dr. Tang, Dr. Tan, and myself were on the panel.
This is Concept Medical's nanolute technology MagicTouch balloon using submicron sized sirolimus particles to diffuse into the deeper vessel layers.
This is the balloon seen over here. It's an 035 platform, fast inflation, deflation, and you can see that with this we do it for 3 minutes, and the final result is much improved. The flow is much faster. With the brachial artery again does not light up, and hemodynamically this is a very satisfying result. I think this goes to show that this technology can be used. We hope that it decreases intimal hyplasia and increases lesion primary patency, as well as circuit primary patency, which is obviously important. The last part just shows you the way that we like to handle the puncture site. There are many ways. I like to do a purse string around it. You can see over here with an absorbable monocryl suture, in this case so that the dialysis center nurse doesn't have to remove the suture and the patient does not have to come back after this intervention. So usually the patient leaves within the hour after the intervention and gets discharged home. There's proximal distal control on the inflow and outflow vessels to minimize any blood spurting anywhere it shouldn't go, and it's just closing of the arterial puncture site. So with that, I'd like to thank everybody for your attention, and we are happy to show you this the way that we do this AVF angioplasty case with a
MagicTouch
drug-coated balloon.
Thank you for this chance to share with you our experience in using Sirolimus Coated Balloon in the salvage of thrombosed AVG. Our patient has been on dialysis for the past 3 years. The first 2 years of using a left AVG, which has since failed Despite the use of stent graft, we can see the presence of stent graft on this chest X-ray on the left side. She's currently on dialysis via the right AVG. This is how the AVG looks like on the previous graftogram performed in 2020. She presented last week with right thrombosed AVG, and the decision was to salvage the graft and treat the graft-vein junction with Sirolimus Coated Balloon. The graft is first accessed in the antegrade direction under ultrasound guidance. It's important to use ultrasound because there's the graft is thrombosed and there's no backflow seen when the needle enters the lumen of the graft. With the use of ultrasound, the needle tip can be visualized and the wire is placed smoothly into the graft. The position of the wire can be confirmed again on ultrasound to ensure adequate and accurate placement of the wire within the graft, as you can see here on ultrasound. In this case, we chose to put a 7 French shift because we were planning to use a 7 mm by 6 cm Sirolimus Coated Balloon at the graft-vein junction after successful salvage of the AVG. There's no need to flush the sheath after the sheath has gone in. This is because the graft is already thrombosed. Flushing the sheath may result in thrombus being embolized down into the artery. We use a 0.035 thermal wire and is supported by a 4 French Bernstein catheter to cross the thrombosed graft. This is how it looks like on fluoroscopy. You can see that there was some resistance that's encountered as the wire crosses the graft-vein junction, but it crossed pretty easily. After crossing, the next step is to do a central venogram. You cannot see much here because the flow within the central vein is very slow due to the obstructed graft. Next, we do a pullback venogram. You can see that the graft is thrombosed up to the graft-vein junction and there's a small thrombus that's sitting right just after the graft-vein junction. Next, we use 4 mg of TPA to thrombolize the graft. This is delivered into the thrombosed graft using the 4 French Bernstein catheter in a pullback fashion. After that, we will recross the graft-vein junction with the 0.035 thermal wire. In some cases where the graft-vein junction is very tight or difficult to cross, we will deliver the 4 mg TPA using a thrombolytic catheter instead. This is to avoid the need to recross the graft-vein junction after delivery of the thrombolytic agent. In this case, you can see that the wire crosses the graft-vein junction easily, and hence we chose to deliver the thrombolytic agent using the Bernstein catheter. Next, we will use the 7 mm by 10 cm Mustang balloon to do two things. Number one, to treat the underlying graft-vein junction, and secondly, to macerate the clots within the graft. You can see that as the balloon is being inflated, the thrombus is being macerated and pushed against the vessel wall. In this case, the graft-vein junction is very tight. You can see that even when inflated to the rated burst pressure of 20 atmosphere, there's still some residual stenosis. This is the appearance after 3 minutes inflation time. There's still some residual stenosis. Next, we will use the same balloon to macerate the clots within the entire AVG. It's important to ensure that the AVG is completely deflated before it's being put back into the sheath. Once we have treated the graft-vein junction and macerated the clots within the venous limb of the graft, we will next obtain retrograde access under ultrasound once again. Here you can see the bevel of the needle entering the graft, and the wire is placed. It goes in very smoothly, signifying that we are probably in the right place. And the positioning of the wire can be confirmed once again on ultrasonography, or in some instances we may use fluoroscopy to confirm the image. Here we put a 6 French shift in the retrograde direction. This is because we are going to use a 5.5 French over the wire Fogarty balloon to draw the arterial plug, and hence the smallest shift that we can place in the retrograde direction will be a 6 French shift. We will use the same 4 French Bernstein catheter and the 0.035 thermal wire to cross into the arterial graft anastomosis. As you can see here, we have actually removed the antegrade sheath and put a purse string around the access but left the wire in situ. This is in anticipation of the trawling of the AVG using the Fogarty balloon. Sometimes the antegrade sheath can get in the way of the Fogarty balloon when we draw. As you can see here, the antegrade sheath has been removed, but the wire remains in situ. You can see the temp crossing of the arterial graft junction. Wire first go down into the distal brachial artery. Some resistance here. It's probably a small branch of the brachial artery. And there it is, the main brachial artery. This is how the graphogram look like. You can see the flow of blood into the brachial artery, and there's no flow within the AVG because it's still thrombosed and obstructed by the arterial plug. We'll use a 5.5 French Fogarty balloon to draw and dislodge the arterial plug. You can see that it's very tight at the arterial graft junction. This is a 4 mm tapered graft. The balloon is deflated slightly to allow the trawling to occur. After the trawling of the graft, you can see some flow within the graft. This is how the graphogram look like, and you can see some residual thrombus within the arterial limb of the AVG. This residual thrombus is macerated using the same 7 mm by 10 cm Mustang balloon. The arterial graft junction is treated with the 4 mm by 4 cm Mustang balloon. This will serve to plasty and increase the size of the vessel, and this is how it looks like after a 4 mm balloon. Still some residual thrombus within the arterial limb of the graft, and this is macerated with a 5 mm by 4 cm Mustang balloon. This is how it looks like. The flow is much better now with minimal residual thrombus. Now the attention is now turned back to the graft-vein junction. As you can remember, there was some residual stenosis despite treatment with a 7 mm high pressure balloon at 20 atmosphere. The graft-vein junction is now treated with a 7 mm by 2 cm cutting balloon before the use of Sirolimus Coated Balloon. It's important to prepare the vessel well because Sirolimus inhibits new internal hyperplasia but does not treat underlying resistant stenosis nor acute elastic recoil. You can see that the stenosis is easily effaced with a 7 mm by 2 cm cutting balloon at 10 atmosphere. This is how it looks like on graphogram after the cutting balloon. We remold the graft-vein junction with a same 7 mm by 10 cm Mustang balloon. And this is how it looks like after the 7 mm balloon. And now we are ready to apply the Sirolimus Coated Balloon at the graft-vein junction. So this is the 7 mm by 6 cm Sirolimus Coated Balloon that we are going to use. It's important to place the balloon exactly where it's supposed to be, including part of the native vein where we have done the angioplasty. And this is the final appearance of the graft-vein junction. You can see good flow within the AVG. The central vein is next checked. And you can see that there are no central vein stenosis. The wire and sheath are then removed and hemostasis secured with purse string suture. And hopefully the patient will continue to use their AVG without any problem for the next 1 year. And I thank you for your attention.
Thank you very much, everybody. Once again, we are back with our esteemed panel. Thank you very much to Dr. Tang for sharing his MATILDA study. Thank you very much to Dr. Chong, Dr. Tan, great cases. We've got Uni Jaffer here from London joining us. Just to remind everybody, they can direct questions through the online bit from Zoom. So back to you, Tjun. What are your thoughts? What are your? I can see you're sitting there a little bit. Let's do some discussion here.
Well, I think we've prepared some very nice questions, Costas, to everyone, and then they will get more tricky as they go along. And I'm going to direct quite a number to you. But let's start with Dr. Jaffer. Dr. Jaffer, I hope you're keeping well in the UK and you've got your vaccine.
I did get my vaccine. It was a bit of a hustle, but I did manage to get it.
Fantastic. So let me start off with a relatively straightforward question. In the fistula space, there are only a couple of randomized trials which have shown evidence of significant efficacy with Paclitaxel coated balloons, without any evidence of mortality signal or harm. Are you confident in this data, and are you using Paclitaxel at the moment? But are you ready to move to sirolimus in view of the data that's just been presented? And if so, what level of evidence do you need to convince yourself to do so?
Thank you. It may be a simple question, but it's actually a very relevant question, especially given the current times. Paclitaxel, when it started, we had, like you do with all of these new technologies, innovators, mainly from that Patros group there and people in Singapore initially showing us in studies, admittedly low numbers, that this was a potentially promising technology. And we were waiting for that large randomized controlled trial, and which we have had a couple. Now, one of those failed to meet its primary endpoint, but nonetheless showed much greater or notable periods of intervention-free periods. And the other one, more recently in the New England Journal, significant differences in levels of patency. There are obviously issues or perhaps things that you can look at with regards to specifics of the trial, namely protocol changes in the first, perhaps slightly affecting the end result, and specifics of demographics, patient populations, and ethnicities treated in the second New England Journal of Medicine. But it is a problem that we have all suffered in that plain balloon angioplasty is really quite inadequate, and we've known this for years. And there are certain areas where we know that neoendomymal hyperplasia is a real problem, which is juxtaanastomotic region, as you showed there in the MATILDA trial, the cephalic arch. So within the UK, we got together a while back and we conducted a Delphi process. We did a systematic kind of literature review and came up with consensus that if we were seeing patients at a certain time period, so within 3 to 12 months after the primary angioplasty, then we would use drug-coated balloons or definitely consider it, and it's been strengthened by that evidence. Now, obviously, we refer to the Katsanos paper when it comes to mortality, and for me, really, it's the science, and then it's what the regulatory bodies are saying, and anything in between that is white noise, because our opinion at the end of the day is level 5 evidence, as much as we like to think it's higher. So with regard to that, I think there are key important differences. Firstly, the fistula is a lifeline, not a lifestyle issue, which claudication is. and there are high rates of mortality within the disease itself, up to a third of patients within 2 years. Nonetheless, if we think about the trials, the numbers, are they enough within those trials to actually confidently say, firstly, that there is no true significant difference? We mistake signals as something which largely probably means it's underpowered for that particular endpoint. And secondly, we're not going all the way out to 5 years, which was obviously a concern of that point. So there are still questions with regard to that.
Sure. So just taking up the point on that fact about use of the trials, let me move to Dr. Katsanos, because he knows a few things about trials and the meta-analysis. What are the lessons learned that from the Lutonix AV trial and the Impact RCT trials that we should potentially translate to any future-based RCT in AVF, Kostas?
Well, that's a great question in the sense that, like Dr. Jaffer pointed out, we have a number of randomized studies that certainly do show significant efficacy with Paclitaxel coated balloons in the short term in the fistula space. And I stress the point here, short term, in terms of efficacy, a reduction of stenosis and repeat procedures between 6 months to 1 year. The jury is still out about long-term efficacy. The potential harm signals, definitely too early to say. And well, I'm gonna point out, the Paclitaxel story still remains a little bit of a roller coaster with certain aspects, but we definitely do need a drug-coated technology in the fistula space. Now, the Lutonix AV and the Impact RCT are great studies. They have definitely set the bar and the standards and the new standards of practice now in the fistula space. And the way we start to see those studies and the lessons learned, they do relate, I think, a lot to the unique design, the dose, the medication, the efficacy. So drug-coated balloons are not just a plain bare metal stent. We need to learn about the unique aspects of the different medications. How is Sirolimus, for example, different from Paclitaxel? We do need to learn the level of dose. Do we need a little bit more of dose? Do we need a little bit less of dose? And how the pharmacokinetic curve and the bioavailability, how long does the medication from each balloon stay into the tissue? And is that dose and tissue level high enough and long enough to have the expected effect, And I think this is what underlines the key differences in the results between the Lutonix AV and the Impact AV study. And Sirolimus, we do need to learn from those studies to apply the same elements into the future studies with the MagicTouch and Sirolimus Coated Balloon technology.
Thank you for that. That's very interesting. And along the same lines of talking about randomized evidence, I go to Dr. Tan. Dr. Tan, there is randomized evidence that a covered stent behaves extremely better than angioplasty at the vein graft junction for stenosis. So are you ready, therefore, to move to Sirolimus coated balloons in that setting, in that indication, knowing that there's good data for putting a stent at that area?
Yes, I agree with you that the stent graft has been shown to be good in the treatment of AV graft or vein junction stenosis. But are we satisfied with the results? The use of stent graft is associated with improved patency over POBA, but there is still, we are looking at about 40% patency at 1 year. And moreover, the use of stent graft can impede surgical revision, especially if the patient has the forearm graft. So is this really the best solution? Do we stop there? I mean, to understand the whole dialysis circuit and arena, we need to understand that the primary pathology at the graft-vein junction is actually neointimal hyperplasia. When we join the graft to a vein, the vein is healthy. But over time, you have a pathological process due to abnormal shear force that triggers neointimal hyperplasia. And the reason why plain balloon fare so poorly in this area is because the post-plasty, the stimulus for the neointimal hyperplasia is still there, and yet you have aggressive healing that takes place and resulting in the re-stenosis that we see with plain balloon angioplasty. Stent graft is helpful because it helps to flatten the whole neointimal hyperplasia. But if you could apply a drug over that area, we could perhaps be able to achieve the same kind of result. Now, the important things between the stent graft and the angioplasty balloon is that stent graft are excellent in treating acute elastic recoil. And it's similar to our pilot study, which we show that if you are able to successfully efface the stenosis, such that there is no residual stenosis, and you apply the Sirolimus Coated Balloon at the graft-vein junction, you can potentially impede and slow down the neointimal hyperplastic response. And therefore, you can get away without the need to place a stent graft in that area and buy the patient potential subsequent surgical treatment if necessary. Of course, if the patient is already on the brachial axillary graft, where surgical revision is actually not possible, definitely if there is acute elastic recoil, then the stent graft may be useful in that situation. But otherwise, I think the use of Sirolimus Coated Balloon definitely open up an option. Now, the situation in Singapore is...
Go ahead. So just a quick retort to you, Milo. So is there something to say that we should be doing an RCT with covered stents versus Sirolimus Coated Balloons in AVG at the graft-vein junction? Is there enough data to suggest that we need that data? Just quickly.
Yes, I think definitely the next step forward would be a stent graft versus the drug-coated balloon at the graft-vein junction to see the outcome between the two. And it could be either a non-inferiority design or superiority design to answer that questions, to find out what is the best treatment. But the question that I always have is, are we happy with 40% circuit patency at 1 year? In Singapore, where the average waiting time for a kidney transplant is 9 years, we have to keep them alive for 9 years before they run out of access. The challenge in certain parts of the world is very different, where the transplant rate, for example, in America and the United Kingdom is much higher than in Asian country. So the challenge in our context is to keep them going before they run out of access and run out of options.
That's a very good point, and well done again for some very good results from your study. Let me move on about some technical issues. Let me move to Dr. Chong, because he showed us a good demonstration of how to do a good fistuloplasty. Dr. Chong, how important is vessel prep in the AVF setting before drug elution? And what type of balloons do you usually use in your practice? And how long do you inflate for, and at what pressures? Do you think this makes a difference? And is there any evidence for this? Because everyone argues for different types of balloons, length of plasty. What are your thoughts on this?
Thank you for the question. I think this is a very interesting session. Vessel prep is paramount before drug-coated balloon application. I think you want to size it appropriately. If we talk about fistulas, obviously we don't want to oversize and cause ruptures. Also because you want to see what the vein looks like before you use a more expensive technology like a drug-coated balloon. In my practice, what I usually do is one-to-one sizing between the HOBA and the drug-coated balloon. I routinely put the balloons up for 2 minutes, sometimes 3 minutes. I think when you talk about data, I don't think there's strong data to suggest there's better efficacy in the AV fistula circuit. However, I think the cardiologists are ahead of us, and they have had some data to suggest that 2 or 3 minute inflations are better in the coronaries. So if we extrapolate from that, I think that longer balloon inflation times are better. Of course, it depends on your patients and whether or not you hyperionize the patient and all of that kind of stuff. In general, I think going to burst pressure is not always the best because you risk dissections. And also for semi-compliant balloons, you may end up with a diameter that you don't want or you didn't plan for. So in that case, unless you have a non-compliant balloon, If not, I think somewhere just 20% above nominal would be adequate. So that's my preference, is to use if possible, a non-compliant balloon. For example, a Mustang balloon from Boston Scientific, O3 system, get it to 20% above nominal pressure and slow inflation like I described during the case, because I find that fast inflation usually causes more problems. And so we want each lesion to pop separately. We put it up for 2 to 3 minutes. 3 minutes is ideal, I think. And also 3 minutes for the drug-coated balloon application. That, I think, is a good way to do it. Thank you.
Thank you very much.
Tjun, we've got a question from the audience. The question states, how do you prevent embolism during the procedure? I think I can address this question to Dr. Tan, and it probably relates, how do you prevent a thrombus embolism when you do thrombectomies? But then, after a quick reply from Dr. Tan, I would like also to address a very parallel question back to Dr. Jaffer, whether he would be worried about drug particle embolization in the case of the fistula space, like it is a concern with Paclitaxel coated balloons, according to Dr. Finn's presentation. So Dr. Tan, back to thrombectomy and back to you, please, quickly.
Yes, so there will be some degree of embolism. Before we start the procedure, it's important to estimate the thrombotic load, the thrombus load in the graft. Now, the thrombus load in the graft in non-aneurysmal type of graft is usually quite low. It's pi r squared with the 6 mm diameter. So essentially, the volume of thrombus within the thrombosed graft is pretty low. It's important to lace it with thrombolytic agent so that you can effectively break it up into smaller pieces. And of course, the other thing that we do is we actually aspirate from the sheath as we do the procedure to try to aspirate as much thrombus out as possible. In patients who have aneurysmal AVF or AVG, we actually use the wall contact thrombectomy device to break up the thrombus into smaller pieces to prevent a significant pulmonary embolism from occurring.
Thank you very much, Dr. Tan. Now, Uni, Dr. Jaffer, what do you think about drug particle embolization? I mean, it is definitely a concern with the old generation Paclitaxel ones. Is it a concern with the Sirolimus ones? How do you perceive those differences? Does it matter to your practice?
No, absolutely. I think that if we look at the Paclitaxel balloons, we know that most is lost during transfer or during balloon inflation. So if we look at some of those studies, that can be up to, and if not exceeding 80%. And the amounts getting into the vessel wall can be between 5 and at best 20%. Now, there's a lot of people who are concerned that when they're going into the below the knee arena, for example, where there is microvascular disease and you're getting this embolic phenomenon, what is that doing into that microvasculature? And is that one of the reasons why we've had issues that we've seen with regards to trials stopping early, etc.? As far as I know, with the Sirolimus balloons, this is less of an issue. Drug transference rates are much higher with the adaptation within the technologies that I'm sure one of you will talk about. And the doses generally within the balloons are lower. Now, when we're in the AVF space, these people have systemic diseases, as we know, and pulmonary reserve in them can be affected likewise. So I think particulate embolization definitely has to be a concern with regards to this, and perhaps it's an advantage that the Sirolimus coated balloons have over the Paclitaxel.
Can I just jump in there, Costas? Do you mind? I've got something for you. I've got a very nice question for you, more of an esoterical question. See whether you can answer this one, because I think it's very important about the mechanistic, how this balloon works. So in terms of Paclitaxel seems to work in the adventitial wall layer, and Sirolimus has the effects on all through the layers. In fact, we have seen ectasia and aneurysm formation with Paclitaxel in the peripheral vasculature, but there have also been reports of aneurysm formation post-Sirolimus in the coronary literature. what are the potential advantages of sirolimus elution over paclitaxel based on this observation, and how can we harness this effect better moving forward in the AVF space? You like that, don't you?
My goodness, Tjun, you have really bombarded me with this question. Now, there are a lot of unknowns here, and it's very difficult to draw parallels between the two medications because, as you pointed out, different mechanism, different distribution, different residence, etc., etc. So I think it's common sense that if the medication is more evenly distributed, and especially if it stays more to the luminal layer, perhaps the drug effect may be better in terms of efficacy. Paclitaxel is well known to accumulate to the adventitial layer and to stay there for a long time. Now, having said that, we also have to remind ourselves that the biology in the fistula space is completely different from the arteries. So I would be very, very careful here to draw any conclusions or to infer conclusions from the arteries. Very quickly, the arteries, we've got neointimal hyperplasia, smooth muscle cells, etc. In the fistula space, and this is unique to the fistulas, basically we've got cells, fibroblast-like cells from the outer layer moving, translocating to the inner layer, and those cells, they differentiate to what we call fibroblast smooth muscle cell-like, the myofibroblasts. This is very, very unique in the fistula. And this is why those stenosis are so tight and so difficult, and this is why we need the high-pressure balloons to begin with. So it's difficult to tell whether, how might sirolimus be better or different than paclitaxel in terms of the effect, because the histology is uniquely different, and we don't have a lot of long-term or any comparative data to do with. But I can tell you, this is going to be a very exciting space to watch and also to monitor and to do studies.
We've got 3 minutes left here, guys. I just want to quickly ask Dr. Chong, moving to the cephalic arch, basically, is there any role of drug elution in this area? And because my feeling is that you probably need a bit of mechanical scaffold in this area because of the fascia. What are your thoughts here, especially in view of the recent results from IMPACT, which showed a benefit of a drug over POBAR in this difficult area to treat? Just give us a few lines there to how your thoughts are about that.
Great. The cephalic arch is obviously a problematic area for the BC fistulas, and it's an area of failure of the circuit. And so many different technologies have been tried, including drug-coated balloons, stents, and covered stents. And all of them, you can find data to support its efficacy. So in general, my feeling is that there is no one-size-fits-all solution. It's important to prolong the circuit patency for as long as possible, as Dr. Tan mentioned in Singapore. The wait time for dialysis to transplantation, 8.5 years. So we really try to prolong it. So I would try with the POBAR, maybe with a drug-coated balloon first, look at the results for that. If there's frequent recurrence, then up the technology or change the technology, assuming that a scaffold is required to, for example, a covered stent. But in the meantime, I think that drug-coated technology, sirolimus, is very interesting because if you can reduce intimal hyperplasia, maybe that's enough to keep the circuit patent and allow dialysis to continue.
I think that's great. We need to wrap up the session, Tjun. I would like to thank everybody. I think we have had a very great discussion, very interesting questions, great cases, a great space to watch here. Back to you for the final comment.
I think this symposium has been very useful. What it's saying is that we got very initial data using sirolimus from good data studies from Singapore. I think there'll be more coming. What we really need is some RCT, which Dr. Tan is addressing at the moment. But I think there still needs to be a lot of basic science that needs to be worked out, because even with paclitaxel, we don't have those answers just yet. So in fact, our results are still very premature. But I think this technology is very exciting, and I think we should watch this space next year, and we should all gather as a group next year to discuss the same things. And I may have even better questions for you next year, Costas.
Excellent. Thank you very much to everybody, guys.
Thank you very much.
You.
Have a nice
Thanks.
afternoon.
Bye-bye.